morning, dear jury members, professors, and colleagues. Today I want to discuss a thorny topic in the peripheral endovascular. I consider it's a hornet's nest. And the topic is either stent or DCB in post-angioplasty popliteal artery dissection. Back to the 4th century before Christ, the famous Greek philosopher Aristotle wrote a book to his son Nicomacheus about principles in life and told him to address any subject in 6 questions. So the Indian poet Kipling wrote about and said, I keep 6 honest serving men. They taught me all I knew. Their names are what and why and when and how and where and who. First of all, what? It's a comparative study studying patency between DCB and interwoven nitinol stents in atherosclerotic occlusive popliteal lesions, who in patients with atherosclerotic occlusive lesion that have a prevalence up to 10% in general population, up to 20% in patients aged more than 70 years, with an annual incidence of a single case every 12,500 of population. Patients were presented rather for the stage from 4 to 6, where in the popliteal artery. Why? It has a unique anatomical characteristics that make it subject to significant biomechanical forces result from repetitive flexion and extension of the knee joint. And as we see, popliteal artery is represented in all types of etiologies and predisposing factors. How the study was conducted? It's a prospective, non-randomized controlled trial. We have a randomized subgroup. Data was collected from patients presented to vascular surgery department, outpatient, accident and emergency department in Asagain hospitals for 1 year. Inclusion criteria included patients without previous stenting and patients presented with Rutherford staging 4 to 6. Exclusion included inability to enter the landing zone, acute embolism, any contraindication for endovascular intervention, and previous stenting of the target popliteal artery. When after vessel preparation and dilatation with PUBA according to the grade of vessel wall dissection. Actually, dissection is a mechanism of PTH controlled dissection, yet uncontrolled arterial dissection is an acute complication that's commonly observed. Many classifications are used for dissection. NHLBI classification, Kobayashi grading system, eye dissections that combine with IVUS. This form classification was released during the preparation of this study. During the study, we adopted NHLBI dissection grading. Patients were classified in 3 groups. No dissection group used DCB. Grade C to F flow-limiting dissections, scaffolding with interwoven nitinol stents. Grade A to B non-flow limiting dissection, either minor radiolucent area or linear dissection. It would randomize either DCB or stent. Why? Because still now, treating popliteal lesion is still a debatable question. Either surgery or endo, and a study in endovascular surgery 2020 showed similar freedom from lesions open compared to endo. In endo, we use DCB or PUPA. Another systematic review showed that primary patency rate was higher in patients undergoing DCB angioplasty. Also in the IMPACT SFA trial, it showed the same result. So either we use perimeter stent or interwoven nitinol stent, and the study showed that superior stent usage in popliteal intervention associated with reduced risk of 1 year freedom of target lesion revascularization. Till now, there is no consensus about DCB versus stent in treating popliteal lesions. Even the question was asked in conference DFCare 2022. There is no head-to-head comparison between DCB and stent. So our results include 74 patients with 76 lesions, 37 in DCB, 39 in stent group, 13 patients has no dissections, 28 flow-limiting dissection, and 35 with minor dissection. As we see, patency was higher at 3 months and 1 year in stent group. Outcome of the results, mortality in DCB was higher in Stent, but it was not related to the procedure. Am I allowed to continue for another minute?